Hello, my name is Dr. Abram Brummett from Albany Medical College, and I have co-authored a paper with Dr. Erica Salter from St. Louis University that taxonomizes views of clinical ethics expertise. So what is the question of clinical ethics expertise? It is relatively uncontroversial that ethicists bring a range of skills and knowledge to help resolve situations of moral conflict or uncertainty in active patient cases. These abilities include mediation and active listening, as well as knowledge of law, hospital policy, and moral theory. What has been controversial is whether, and if so how, ethicists can make justified ethical recommendations in active patient cases. In other words, can ethicists make authoritative claims about what is ethically permissible, obligatory, or prohibited in the clinic? This is the question of ethics expertise, and it has been debated by theorists of clinical ethics for decades. We find the question of ethics expertise to be both confused and confusing because it is difficult to pinpoint exactly what the question of ethics expertise is about and which positions are being advanced on the question. We begin by presenting and critiquing the approaches to clinical ethics consultation outlined by ASBH for oversimplifying a complex question and controversially presuming that ethicists do in fact have ethics expertise by claiming they can determine the range of ethically acceptable options in active patient cases. In its place, Dr. Salter and I attempt to sketch a taxonomy that better approximates the range of options available in this debate, so theorists can identify their positions more clearly and disagree more productively over this question. Our taxonomy begins with the orienting question: can clinical ethicists offer justified normative recommendations in active patient cases? Views will be categorized based on how they answer this question. Those that answer no will be characterized as having a negative view of clinical ethics expertise and will be further differentiated based on A, why they think ethicists cannot give justified normative recommendations, and B, what they think ethicists can offer if they can't offer recommendations. Those that answer yes to the orienting question will be characterized as having a positive view of clinical ethics expertise. Positive views are distinguished according to 4 additional questions. First, how are those recommendations generated? Here we import the discourse on clinical ethics consultation methodology and offer 2 dimensions of characterization. 1, procedure-heavy generation versus rule-heavy generation, and 2, consensus-dominated generation versus individual-dominated generation. The second question for distinguishing positive views is what is the nature of recommendations? Here we distinguish between process-heavy recommendations versus content-heavy recommendations. Third, we ask how are recommendations justified? Here we discuss possibilities for justification at both the meta-ethical and normative levels. And finally, positive views are distinguished based on how recommendations are communicated, either in a more declarative or a more dialogical fashion. Our aim in this paper is not to articulate an exhaustive taxonomy, but to offer a framework upon which we have invited other theorists for clarification and expansion. Dr. Salter and I are very happy with the response from our colleagues and look forward to future work refining this taxonomy. Thank you.